Morning, guys. So in today's vlog, hello guys, can you hear me? Mic test, mic test. Ooh. Hello guys, can you hear me better? Mic test, mic test. So guys, dahil hindi ako kontento sa recording ko, gawa na ako ng PowerPoint presentation. Hi everyone, and welcome to a lazy day with me again. So today's topic will be about the differences of being an operating room nurse in the Philippines versus in the UK. So just a disclaimer, in the Philippines, I am working in a private hospital in Iloilo. And then here in the UK, I am working in a government hospital under the NHS in central London. A lot of the things that I'm going to talk about is my experience in my hospital, but I also asked some of my colleagues from the Philippines who are also here working in the UK right now as the operating room nurses. Let's start with that. So first of all is the term. So in the Philippines, you are called an operating room nurse. So you work in the operating room. But here in the UK, you are called theater practitioner. So you are working in the theaters, with the emphasis on the spelling of RE instead of ER, because UK English. So just something to know, when I came here in the UK, I went straight to the theaters. Some of our new starters went to have an exposure in recovery in preparation for their OSCE. But then for me and my other cohort, the one that I started theaters with, so we just told them that we don't really need recovery exposure for our OSCE, since we think that OSCE is more on a scripted dialogue with the patient, especially that it is time pressured. In the case of some colleagues, some friends that I have met here, they were theater nurses in the Philippines and they meant to apply to be a theater nurse here in the UK. Unfortunately, some of the trusts, they don't have any vacancy for theater nurses, so they just come here to be in the ward, or they were assigned in the ward. So in that case, what they do is, after probably a year, or it depends, or if there is vacancy, then they will just ask their manager, or they can check the job vacancies and apply for a transfer to the theaters. So I also have one colleague who worked in the ward when he came here, and then since there's no vacancy in theaters, he applied to do bank shifts or extra shifts in the day surgery theaters in their hospital. Most of what they do in the day surgery theaters in that hospital are lab cases, and he definitely knows and very skillful in lab cases in the Philippines. So while waiting for vacancy, he does that at least to be in touch with his theater skills, and also at least for connections in case there will be a vacancy in theaters, so at least they already know him. Another difference between UK and Philippines is the level of sterility. So in the Philippines, we have an outside scrub uniform that we wear going to the hospital, inside the hospital premises, and then we have a separate inside the theater scrubs. Every time we go inside the theater, we change our outside scrubs uniform into our inside theater uniform. And if we go out of the theaters, like if we are going to indoors the patient to the ward, we have to change from our inside scrubs into our outside scrub uniform. However, here in the UK, just like I've drawn previously, so for theater staff, we don't have a specified uniform, unlike in the ward wherein you have the blue NHS uniform. So we just go to the hospital in our casual clothes, and then the hospital just provides the scrub. We change into the scrub uniform, and then we can use that whenever we are inside the hospital, and then we don't have to change. We can just go in the theater, and then we can just go out of the theater in the same scrubs, and you can just roam around the hospital with the same scrubs. Although in this time of COVID, since we have different pathways for COVID patients and non-COVID patients, so if you are assigned in the COVID pathway, and if you are going into the non-COVID areas, you have to change your scrubs. Next is probably their awareness of the sterile field. This illustration might not be really a good illustration because it's not really about the place, but it's more about the awareness of probability of touching the sterile field. So in the Philippines, of course, when someone changes a glove, so there might be chances that your hand, which is unsterile, might be exposed, and of course there are chances that you might touch the sterile area. So from what I can remember, in the Philippines, usually the circulating opens the glove, and then at least the surgeon will reglove outside of the sterile field, or actually easier, the scrub nurse will serve the surgeon the gloves. But here in the UK, since the scrub nurse doesn't really serve the surgeons the gloves, they will just take their gloves with their hands bare, and then they will open the glove packet on the sterile field. The hand which is bare, which is unsterile, might touch already the glove packet, and then it will touch the sterile field. So there are just high chances of your sterile field being contaminated. So it's up to you as a scrub nurse to protect your sterile field. You really have to watch out for it. Another example is when I first stepped into the theater, I was surprised because they are not wearing masks. Only wear mask if you are scrub, but if you're circulating and you're not really scrubbing, then you don't really need to wear it. I think it's when COVID started, everyone is wearing masks, not only in the theater but as well as around the hospital. I think it's because of their evidence-based studies. I think partly evidence-based practice can save you some of your resources. But then during the pandemic, I think that's where the UK was delayed. They are too focused on their evidence-based practices that the government sort of lacked the common sense, because since COVID is a respiratory problem, then of course you have to wear masks. It's an infection, so you have to break the chain of infection. I don't know why the UK was delayed in the airport quarantining in the hotel thing, when the Philippines has done it for months. So another difference is the theater structure. In the Philippines, your theater is usually composed of one circulating nurse and one scrub nurse. So it's just the two of them running the theater. So since it's just the two of them, so if they have case after case, they will just relieve each other as a scrub, and then the circulating, if it's a long case, then he or she can a really quick break. But then otherwise, if it's too busy, then they really don't have any breaks unless someone is free from other theaters to relieve them. Also, in this kind of structure, like in the Philippines, the circulating nurse is the one who receives the patient from the ward, and then the circulating nurse will answer to 3 masters. So he or she is there for the orders of the anesthetist, and then if the surgeon wants something, and then as well if the scrub nurse will want something. So being a circulating nurse in the Philippines is really stressful. Meanwhile, in UK theaters, you have 2 nurses who can both scrub and circulate. And then you have your TCA, or your theater circulating assistant. So TCAs don't have any license, they are not qualified, so their role is just to circulate, and they can also give any medications. Apart from the three, you have an anesthetic person. So it could be an anesthetic nurse. So it's a nurse who underwent a course for anesthetics. Or it could be an ODP. So ODP, I don't know what the meaning of ODP is. But then they don't have a license, and they are not nurses, but they have taken like a fast track course wherein they are trained to be scrub, anesthetics, and recovery. But I think in UK as a whole, they are short on ODPs. So usually when the ODPs graduate, they usually go for anesthetics, just because there are a lot of vacancies in anesthetics. So as for the roles, so anesthetics answer to anything that the anesthetist needs. So he or she will be the first to meet the patient together with the anesthetist to do the sign-in, prepare the patient, attach the patient to the monitor, prepare the medications for the anesthetist. So his or her role is only with the anesthetist. Meanwhile, the three scrub team, their focus is only what's inside the theater. Since you have two nurses and another TCA, they can relieve each other for breaks, especially here in the UK, that they really force you to take your break. You can't say no to your break. You have to take it. Another difference is probably the range of specialty, well, difference and sort of similarities. In the Philippines, well, probably there are specialties, especially the specialty hospitals in the Metro Manila region. If you're outside Manila, usually like just general hospitals, so it's like you have to do everything. You have to know how to scrub and circulate for whatever case that will come to your door. So in the UK, it really depends on the trust. So a trust is a cluster of hospitals or clinics serving that certain area. So for example, in my trust, there is this one main hospital wherein theaters serve different specialties. But then it has peripheral sites which are more specialized. So one hospital specializes in urology cases, one hospital specializes in urology cases, and one hospital specializes in ears, eyes, nose, and throat. As for me, I'm working in the main hospital, so maybe in a way it's similar to my practice in the Philippines, wherein you are an all-around scrub. So just to give you a glimpse of my weekly allocation, so you will see here the 3 types of time per day. So our work starts at 8, and usually the finishing time varies. So sometimes we finish at 5, you can finish at 7:30. Mainly that's because we are doing electives, and then you have long days. So for example, Monday I'm assigned in breast surgery list, and then Tuesday I'm off, Wednesday I'm long day. So usually if you're long day, it's either you would be assigned in the trauma theaters or in obstetric theaters. So yeah, obstetrics, because you don't know when the babies will be born. Thursday I'm 7:30, so probably they'll put me in a list that finishes at 7 p.m. So for example, colorectal list. And then Friday I'm off, so I'm gonna gala somewhere else. And then Saturday I'm off. Usually if weekends, it's either your long days or night, so really 12-hour duty. So either you're in trauma theaters or in obstetric theaters. So there are some hospitals who have a different structure than in our hospital. So instead of having just one whole theater team, We have specialties, but there are times that we are allocated in different theaters as well. But in the case of other hospitals that I know from my friends, so they are in one hospital and they have different theaters, but then whatever specialty they have, they are just concentrated on those specialties. So they don't really get to mix around or work around other specialties. So for example, if you're in ophtha, then you're just doing ophtha all the time. And if you're assigned in ortho theaters, then you're purely just doing ortho cases. And so on. So usually they don't really mix with each other. So theater nurses from other hospitals, correct me if I'm wrong. But yeah, that's the thing, that whatever your specialty is, your focus is only on your own specialty. Another difference is probably the amount of sets and instruments that you have to learn. In the Philippines, in my hospital, there are only a few sets. We have excision set for smaller procedures, outpatient procedures such as excision of small tumors, excision of cyst, and then a minor set for finer instruments such as if you need it for thyroidectomy, and then you have your major set which you need for bigger anatomical bodies. So like for example your laparotomy cases, C-sections, and then you're just going to pick up whatever special instruments that you need. Each type of instrument is being packed individually. For example, your bowls, your kidney dish, your set of Alice's, your Balfour retractor, your set of 3 divers with different sizes, and etc. But here in the UK, you have lots of instruments to remember. I think that's partly the reason why if you are assigned here in a hospital which only focuses on one specialty, it would be an advantage for you, because at least it would be easier for you to learn because you only have one specialty to learn. But like in my hospital, because we are doing different specialties every now and then, so we have to know all of the instruments. So you have set, plastic, hypospadias, DHS, minor urology, major urology, 813D, 813C, that's for the lap sets, major vaginal, minor vaginal, fetal surgery sets, cystoscopy, different sizes, GME, DNC, ML, FES, Midas Rex, and then different systems for your instruments, cordless system 7, tracheostomy set, oral surgery set, and more. So slightly in relation to that, in the Philippines, when you're a scrub, you have a Mayo table and then you have your back table. So Mayo table is where you put your main instruments, and then your back table for all your other stuff or bigger stuff such as your bowls, your kidney dish, and all the other things. And then in the UK, they don't really use Mayo table except for obstetrics, because I think it's the obstetric surgeon's preference. You usually just have one trolley for your instruments, and then because they don't have any individual instruments, so if they need just one instrument but it's not in your main set, then you have to open another set, and then that's one tray again, so you have to have another trolley, and then if you need another more, and then you'll have another trolley, and if you need more, then there's another trolley. So well, I'm kind of exaggerating, but sometimes it does happen. So of course, speaking of sets, there will be differences in terminology of the instruments. So for example, they call mixture as Leahy, straight Kelly's Spencer Wells, Richardson retractors Morris, Sen and Drake, Cat's Paws, Yeah, so you have to adjust. So I also had to adjust with all the terminologies of the instruments as well. So not only do I have to adjust with the terminologies, I also have to adjust to how I say the words, because if I just say it in my normal English, then they sometimes some of them would not understand it. So just one example, I was giving the cord scissors to the midwife, but then the midwife was, what? And then I keep on repeating cord scissors, cord scissors. And then I realized it's my American English that I'm pronouncing the R, and then I'm pronouncing the OR in the scissors, like really hard scissors, cord scissors. Yeah, so I adjusted and then I said, oh, code scissors, scissors. And that's when she understood what I said. One difference as well is that I think, in my experience, there is an equality here in the UK compared in the Philippines. In the Philippines, there is really a hierarchy wherein doctors are higher compared to the nurses. But here in the UK, we were taught to instill that in our minds, that we are all equal inside the operating room. So as what my colleague had pointed out, most of the surgeons in the Philippines, they just hurry, you know. It is greatly appreciated in the Philippines, those surgeons who are really calm and they understand that the nurses need to prepare the operating room theater, to prepare the equipments, and to prepare everything that is needed for the procedure to go smoothly. But then some surgeons really just don't understand it, and they don't even give the heads up of what they need, especially if it's a special equipment. So there are certain equipments, instruments that we have to look for availabilities. There are also certain factors where, for example, staffing needs, for example, availability of the operating room. So here in the UK, before every list, or before, as much as possible, every case that we do a team brief. So even in emergency cases, even in like sections which are really emergency, but then there is certain teamwork so that everything will run smoothly and there will be no delays. So they take time to do a brief, just at least a very quick brief, so that everyone is prepared on what to do. So the surgeons, the nurses, or the scrub team, and then the anesthetists will talk through about the patient. If in the obstetrics, then the midwife or the neonatal nurse could be present. So during that brief, everything is communicated. So the surgeon will tell the team about the patient, and the anesthetist, who probably has seen the patient already, they will discuss about the medications that he or she is gonna give during the procedure, what are the comorbidities of the patient. The surgeon will tell the scrub team what are the instruments needed, the sutures needed, if there is any equipment needed as well. And then the anesthetist will also tell the ODP what to prepare. Is it for a general anesthetic? Is it for intubation? Is it for spinal, an epidural? And then also for procedures such as tracheostomy, wherein there should be a smooth flow of the procedure. So the surgeons and anesthetists will talk through when are they going to move the tube and all of those things, and then to make sure also that the nurse is prepared and the tube has been checked. It just takes a few minutes, but then it will really save you time, because you avoided miscommunication. Everything is ready, and the most important thing is that teamwork and the communication is for the patient's safety. So apart from this are the differences like disposables here in the UK, whereas in the Philippines, non-disposables, and then also the computer system for medical records, where in Philippines still use paper, and here computers for medical records. So guys, thank you so much for watching, and like what they say here in the UK, you're a star, you're fantastic, good job if you have reached the end of this video. So comment, like, and subscribe.